and we want to go ahead and get started. We want to be respectful of everybody's time. It's 3 o'clock, and I just want to first off thank everybody for taking time out of their day today to listen into this webinar. As I started to say before, currently everybody is in listen-only mode. We're doing that just for the first 25 minutes or so as we go through our slide deck in order to prevent any sort of feedback or background noise. But after we get through the prepared portion of this, we're going to unmute everybody so we can have a discussion. And if folks have questions, we'd be happy to answer them. We're also recording this webinar to be able to send out to folks who are not able to join us at this time. Just want to make sure everybody keeps that in mind and is aware of that. But again, thank you for taking the time to be with us today. Excuse me. So the objectives for today, we would like to, when folks are through listening to this webinar, have everybody have a better understanding of the CMMI Transforming Clinical Practice Initiative, also known as the TCPI, and the Practice Transformation Network, PTN, arm of that program. We'd also like to convey the work that Crystal Run Healthcare is doing to submit an application to be a PTN, and that we're inviting eligible providers and practices to join and align with our network. We're also going to go through some of our internal transformation successes to give a better idea of who Crystal Run is and what our capabilities are, and then finally understand the benefits of joining the PTN for each of your individual practices. And actually, that's where I want to begin. I'm sure many of you on the call have heard a little bit about the TCPI and about our efforts here, but I wanted to start right off the bat with, why would a practice be interested in aligning with our PTN? And the benefits to the practice, again, there's no direct financial gain. Practices are not able to be paid directly or reimbursed for participation. But what you will be receiving is free consultative services regarding clinical transformation. So as we go through the presentation and we go through the different capabilities and offerings that Crystal Run Healthcare has for practices that are interested in aligning with our network, you will have access to all of that for free, and we will be at your disposal for those services. Also, as far as tangible benefits, you will receive assistance with PQRS reporting to prevent financial penalty. As many of you know, the PQRS system, when it began several years ago, was an incentive. Practices were able to be paid a bonus payment for participation, but that incentive has gone away and has been replaced with a penalty for practices that do not report. And so we will be able to assist practices with reporting and prevent them from being subject to that penalty. Along those same lines, again, as many of you know, the way that healthcare is moving is toward accountable care and toward skinny networks, narrow networks, value-based networks. Choose your description of these networks, but many insurers are now limiting participation in their networks to practices that have capabilities of being able to improve quality, improve the patient experience, and lower the overall cost of care. By participating in this program and aligning with our network, you will gain competencies in these areas and make you more attractive to commercial payers. As far as cost, again, there's no financial cost whatsoever to participate in the program. Really, the only cost would be your time to participate in the programs and efforts that Crystal Run Healthcare is offering to all of the practices that are aligned with the network. So I want to spend a little bit of time going through what the program is, but in order to understand that, you need to understand a little bit about what the Innovation Center, or CMMI, is. It was established through the Affordable Care Act, and its purpose is to test innovative payment and service delivery models that both improve quality and lower the cost of care. It was funded with $10 billion over the course of a decade and must report to Congress every 2 years on its progress. The Innovation Center is what's responsible for the Pioneer program, which I know many of you have heard about, and also what's responsible for round 1 and round 2 of the innovation grants that were awarded last year and the year prior. CMMI's latest initiative is this TCPI program. And the TCPI program is set up with 6 goals. First, to support 150,000 clinicians across the country to transform their practices in ways that we're going to elaborate on throughout this presentation. Second is to build an evidence base, really a best practice library on what tends to work when trying to have practices transform, and then be able to scale those solutions across the country. Third is to improve health outcomes for 5 million Medicare and Medicaid beneficiaries. Fourth is to reduce unnecessary hospitalization and overutilization. Fifth is to generate between $1 billion and $4 billion in savings to both government and commercial payers. And lastly is to move 3/4 providers that are aligning with the networks to some form of value-based payment model. And that could be as little as PQRS reporting for the value-based payment modifier, to as much as participating in a shared savings arrangement or a capitated arrangement or something along those lines. So the way that the TCPI is set up is in 2 arms. The first arm is the Provider Transformation Network, or the PTN network. This is the arm that we are pursuing. This arm is geared towards medical practices, health systems, and state organizations such as the QIOs. There is a second arm of the program, which is the Support and Alignment Network, or SAN. This is geared more towards medical associations, professional societies, and foundations. And the way that the program is mapped out is over the course of 4 years, which is the length of time of the grant opportunity. Practices will pass through 5 phases of the program. Phase 1 is doing a readiness assessment and setting aims and developing basic capabilities for each of the practices. Phase 2 is reporting and also using that data to generate improvements. So part of the requirements for the program is for us to be able to provide each of the practices with monthly scorecards on their quality metrics, and then provide CMS with aggregate quarterly scorecards for all the practices that are aligned with our network. Phase 3 is achieving the aims of better health care at a lower cost, also known as the triple aim, which we'll talk about in a moment. Phase 4 is to start achieving benchmark status, those benchmarks that were set up in Phase 1. And Phase 5 is that the practices have demonstrated capability to generate better care and better health at a lower cost. So who is eligible to align with our network? Really, any provider that is not already participating in a CMS, ACO, or a CMMI comprehensive primary care initiative. So providers that are already part of the Medicare Shared Savings Program or the Pioneer Program are not able to align with a network. For each PTN, so for all of the practices that align with our network, we need a minimum of 20% of those providers to be some combination of small practices, meaning less than 9 providers, or located in a rural or underserved region. So that's a little bit about the program. Dr. Nasser is going to go through the capabilities and the offerings at the end, but now I'm going to shift gears a little bit and talk a little bit about Crystal Run and about some of the work that we've done over the course of the last 4 or 5 years. So for those of you who are not familiar with Crystal Run Healthcare, we are a physician-owned multi-specialty group. We were started in 1996 with our original 8 partners in Middletown, New York, which is in Orange County. Between 1996 and today, we have grown to now over 325 providers across greater than 20 locations in Sullivan County, Orange County, Rockland County, and Manhattan. We have approximately 40% of our providers as primary care physicians and about 60% of our providers as specialists. You can see here we have a wide variety of tools at our disposal for providing outpatient care, high complexity labs, pathology departments, a joint venture ambulatory surgical center with our local hospital, multiple urgent cares, sleep centers, etc. We've been on electronic health records since 1999. We've been on the NextGen platform since that time. We were the first Joint Commission accredited private practice in New York State in 2006. And we were early level 3 NCQA patient center medical homes in 2009, and again recertifying all of our primary care sites in 2012. That's Crystal Run Healthcare, the practice. Crystal Run Healthcare, the ACO, is a single entity ACO, meaning that it is comprised solely of Crystal Run Healthcare, the medical group. We were one of the first 27 participants in the Medicare Shared Savings Program with an April 1, 2012 start date, so we're entering our third year in that program. We're also one of the first 6 ACOs in the country to be accredited through NCQA, and the first in New York State. We have approximately 25,000 commercial lives in some sort of at-risk contract across our various payers, and we are approaching now about 11,000 attributed beneficiaries in the Medicare Shared Savings Program. So when we began our transformative journey about 4 or 5 years ago, what Crystal Run Healthcare used as our rallying cry is the triple aim. And for those of you who are not familiar with the triple aim, it boils down to better health, so improving the health of the population, better health care, which is enhancing the patient experience of care, and lowering the cost of care. So better health care at a lower cost. And the reason why the triple aim spoke to us so dramatically is because if you look at our mission statement, the tenets and the goals of the triple aim are weaved throughout our mission statement. So you can see there quality of care, availability of care, satisfaction with care, medical excellence, service excellence, patient empowerment. These are all goals of the triple aim that have been a part of what Crystal Run Healthcare has been all about since day one. And what's interesting is that our mission statement was actually written in 1997, years before Don Berwick coined the triple aim. This slide just shows some of the hallmark events that have taken place over the course of the past 10 years or so as we've been transforming to an accountable care organization. Again, you can see here many building blocks that have built upon itself. I'm not going to read through this or go through every single piece of this. You'll all have the slides to be able to look at this, but would just stress that we've been on this journey for a long time, and we've invested a lot of time and treasure in being able to build these capabilities, and we want to be able to share those with the practices that are aligning with our network. So just going to spend a few minutes now going through what we have done here at Crystal Run to improve quality, improve the patient experience, and lower cost. One of the first things that we did as a practice when it came to improving quality was to develop a best practice guideline library. In some areas of the country, there's a lot of collaboration between medical practices to build best practice guidelines for treating chronic conditions or preventative services. That does not exist in New York or New Jersey, and so we felt that this was so important of an effort and so important to improving quality that we wanted to do this internally. And so what we would do is we would pick a diagnosis that was common here in the practice. We would assemble representatives from involved specialties. So, for example, when we looked at osteoporosis, we gathered together some primary care providers, some OBGYNs, and some endocrinologists, went through the current literature on best practices for treating that condition, and boiled it down to 1 page or less in an interactive form that we submitted to our Best Practice Council, which is comprised of our clinical division leads. They would then approve, review and approve the guidelines, and then be posted on the intranet for our providers to use at the point of care. And this screenshot here just shows one example of a best practice guideline that's on our intranet for folks to use at the point of care. We also have implemented several continuous quality improvement initiatives for specific diseases as we saw the need to do so. One of the first that we did was for diabetes control. Back in 2008, 2009, our hemoglobin A1C greater than 9 percentage was up around 18% or so. And in order to improve this, we would have the endocrinologists each meet with a handful of primary care doctors, a care manager, and a dietitian once a quarter. We would go through the list of patients that were attributed to those primary care doctors who had A1Cs greater than 9, and we would identify patients that may not have been seen in over a year and have the care managers reach out to them and re-engage them in their health care. We would identify patients who may already be on insulin regimens, and the primary care doctors just needed some curbside assistance from the endocrinologist on how to titrate their regimen, and we would do that right there and then. And then we would identify patients that needed formal endocrinology consults, and we would arrange those in a timely manner. And you can see that our A1C greater than 9 rate drops precipitously and has stayed down since that time. When it came to blood pressure control, we identified blood pressure control as an area that we could improve, and we looked at what are the barriers to achieving good blood pressure control. We identified two things. One was the lack of a blood pressure protocol, a standardized way to prescribe and titrate antihypertensive medications. So we put a working group together to come up with that and develop that. But we also realized that the copay for patients to come back and have their blood pressure rechecked within 2 weeks, 4 weeks of that visit where a blood pressure medication was started or titrated was a barrier for many patients to coming back. And so what we decided as a medical practice was that blood pressure control was too important of a clinical measure to let a copay stand in the way of success. And so we provide this service now free of charge. We don't charge the insurance company. We don't charge the patient. They come back 2 weeks, 4 weeks later for a blood pressure check. And if their blood pressure is not in range, the protocol is followed and the medications are adjusted. And so patients are able to get to goal much faster. And you can see what the overall results of that were on this graph here. LDL control for patients who have coronary artery disease, again, through comprehensive education in our primary care doctors and our cardiologists, through CMMI-like events. You can see what happened to our LDL control. And then lastly, breast cancer screening, our mammography rates, looking at what happened to those over time. Again, looking at barriers to breast cancer screening, we've been sending out letters for years to patients that are overdue for breast cancer screening. Those letters would ask patients to call and schedule a mammogram. They would call and be told that they need an order for mammograms to be performed and that they should make an appointment to see their primary care doctor or their OBGYN. Obviously, this was a barrier to having them get the test done, so we now have a universal order for all patients here at Crystal Run who have OBGYNs and primary care doctors in the practice, so they can call and schedule that test. And we also instituted walk-in availability, so these letters that go out now ask women to call to schedule their mammogram or to walk into any of our sites and they can have their mammogram performed that same day. So those are some specific QI projects that we put in place here at the practice. I'm going to hand it over now to Dr. Nasser to go through the remainder of our slides, and then we're going to unmute everybody so that we can have a discussion and answer everybody's questions.
All right, well, thank you, Scott. I'm John Nasser. I'm an internist and pediatrician here at Crystal Run Healthcare, and with Scott, Dr. Hines, myself have been working hard here at Crystal Run over the last 4 years or so at our own internal transformation. With the remainder of our prepared comments over the next 15 minutes or so, I wanted to carry further what Scott had brought you up to speed with and focus now on some of our work around controlling the cost of care. One of the things that we've done internally is to embrace and implement the Choosing Wisely campaign within our organization. I think many are probably aware of Choosing Wisely. This is an initiative from Consumer Reports and the American Board of Internal Medicine, which charges specialty societies to identify those things that physicians and patients should question. And specifically, the goal of this initiative is to identify things and identify care that is truly needed, non-duplicative, and free from harm. One of our internists created a campaign to implement the family practice Choosing Wisely recommendations in one of our medical home sites, and I wanted to share with you some of the results here about that. One of those recommendations is to not do imaging for low back pain within 6 weeks of onset of symptoms. This was something that we had been talking about as an organization. It's actually a meaningful use measure as well. But part of this campaign allowed us to further see a reduction in utilization of imaging in this setting. You can see here that prior to the effort in 2012, our baseline imaging rate is shown there in red. And in 2013, both before and after the initiative, we saw a further reduction. Now, I'm certainly not suggesting that the Choosing Wisely initiative led to this decrease in 2013. It was already underway. But what was interesting was this gave us an opportunity to engage our physicians and our patients in this initiative with discussion points around the right amount of care and the utilization of imaging for this diagnosis and for others. So in addition to lowering costs, it was a great way to engage our patients on discussions about utilization. Another initiative or another recommendation that we looked at was EKG use. One of the Choosing Wisely recommendations for family physicians is to not do screening EKGs in asymptomatic patients. Again, we had already been speaking about this, but in 2012, 2012, you can see our baseline rate in red. In 2013, both before and after the intervention, we saw a further reduction in the use of EKGs, both at annual physicals and in all visits in adult patients. Next, I wanted to share with you the results of a best practice pathway for breast cancer that two of our oncologists developed as part of an innovation contest that we held internally. This was a pathway that was put into place in 2013, and one of the specific things that was looked at in the pathway was the use of pegfilgrastim, which is an expensive colony-stimulating factor that is sometimes used in the treatment of breast cancer. You can see that for our 4 oncologists, both before and after the pathway, we saw a reduction in the use of pegfilgrastim, and overall we saw the same. Although not shown here, the quality of care and of these patients was the same or better in 2013. The next slide shows that both in 2012 and in 2013, with about 800 patients, and specifically looking at the reduction in pegfilgrastim alone, we had a total cost savings of $225,000 for the treatment of this 800 patients. And this was not a cost savings that came to us. It actually went to the plans and in terms of who had this savings. But we thought it was a dramatic impact in terms of the care of patients with looking at one simple intervention. If we look at the use of PET scanning and radiation therapy that was developed or looked at through the pathway, if we look at the reduction in those things, the savings approaches $2 million. And again, I think one of the great things about this intervention is that 2 of our physicians brought it to us as part of an idea that they had to reduce the cost of care for our patients. The next slide depicts our variation reduction program, and for those of you who have spoken with us before, this has been a very important part of our work here internally at Quistarun, and I kind of view this as our secret sauce in our transformation work. There are 3 steps in this process. The first is to identify or to present data on variation in charges per patient. I'll explain that in a second. The next step is to analyze the variation. And then the last step is to develop best practices around the standards of care for managing a certain diagnosis. So what this graph depicts on the x-axis is all of our primary care providers. And on the y-axis is our charges per patient for diabetes on a yearly basis. When we present this data, and this was our pilot diagnosis that we looked at, when we presented this data to our providers, it was done in an unblinded fashion so that all of the doctors' names were on this chart and they could see their charges per patient with diabetes over the course of a year. Now the charges per patient is a surrogate for cost because it does not include hospital charges and it doesn't include pharmacy charges. It really just looks at our internal charges. And although you might suggest or might think that that's not comprehensive enough, one of the things that I would point out is that this analysis is available to any of us who don't have claims data but simply are looking at their own internal charges. And given that, we thought it was a good place for us to start. Over the course of 2010, when we launched this initiative to 2012, we saw a reduction in our charges per patient for diabetes. That's comparing the blue and the red here. And overall reduction in the variation of care when we asked physicians to take a look at what was going on with their charges. And really what happened when speaking with the physicians was that this had nothing to do with the quality of their care, and it had nothing to do with how sick their patients were. But it had everything to do with getting our physicians to agree on what the standards were and what the best way was of taking care of diabetes. This was armed with a well-published and a well-identified evidence-based practice from the American Diabetes Association, and we identified through our physicians opportunities for reducing unnecessary care when looking at improving the quality of care for diabetes. We then brought this variation reduction project to 14 additional diagnoses and specialties throughout the organization. And you can see these additional diagnoses here. And through this same process of analyzing the variation in charges and asking for the specialties to develop best practices, we saw a reduction in charges per patient for these 14 diagnoses of $4 million. You might wonder why we would want to reduce our charges by $4 million was really reducing our revenue by that amount. But the next slide shows you the business model for pursuing this. Between 2011 and 2014, our receipts per patient on a per patient basis went down by about 20%. That's the line that you can see in red here. But during that same time, our distinct patients, or our new patients into the practice, grew. One of the things that I'll show you in a second is that part of this strategy involves reducing unnecessary testing and unnecessary visits and backfilling those with new access and new capacity for patients. This is a really important skill to have and ability to have as we take on risk, especially when we're being evaluated based on the number of patients in our panel and the number of patients that we can take care of. Through the course of this effort, through variation reduction, we've successfully done less on more patients, and that is a very successful strategy to have in one that is pursuing a value-based care strategy. The next slide really gets into the details of access, and as I mentioned earlier, as part of this variation reduction work, we've identified opportunities to eliminate unnecessary visits. So again, these are the same 14 diagnoses that I mentioned, and on a visits per patient basis over the course of this initiative, we reduced our visits by almost 13,000 visits. Nonetheless, our patient base grew, and we had almost 2,000 new patients with these diagnoses. So on a practice level, when we take a look at what was going on in the organization, not just with these 14 diagnoses, but with the overall care and with an overall culture at Crystal Run of efficiency and of doing the right thing and eliminating things that aren't adding value, we saw the ability to create significant access in our practice. So this graph shows in yellow our total visits, and you'll see those growing from 2010 to 2012. In red, our visits per patient, which were going down, and in blue, the growth in our distinct patients. So overall, for our practice on a visits per patient basis, we had almost 42,000 fewer visits, but we had 30,000 new patients. And when doing some math around average visits per year seen by a provider, we've essentially created the capacity for 12 new physicians without hiring those new physicians by eliminating unnecessary visits to the practice and backfilling those with new patient visits. Again, this skill set brought about by variation reduction and developing best practice standards is a really important one when we're taking on risk and attributed lives into our organization. Briefly, we've had a lot of success and experience with transitional care. Our version of transitional care involves our care team. So this involves our effort at reducing readmissions to the hospital. This program was inspired by CMMI's first innovation sort of contest or plan that came out about, I guess, 3 years ago now. CMMI has gone on to have a second round of innovation, and now this grant that we're talking about with you guys today. But part of this transitional care program was designed to reduce admissions, readmissions, and length of stay through a home visit program. And this next slide depicts our process. Essentially, high-risk patients who are admitted to the hospital are evaluated by our care manager who's at the hospital, and a warm handoff occurs to our care manager in the office. We then go and see those patients within 1 to 3 days of discharge by a mid-level provider who does a provider evaluation in the home, and one of the most valuable things that happens is an in-home medication reconciliation. That visit does not take the place of the primary care physician visit, which still happens within 1 week of discharge, and our care managers follow these patients for at least 30 days after discharge. Through this transitional care, we've seen a reduction in our Medicare 30-day readmission rates, as is depicted on this slide. Overall, we've done well in reducing the cost of care through a number of ACO contracts that Dr. Hines mentioned early on in the presentation. And you can see some of those here. With 2 commercial payers, we reduced the total cost of care by between 6 and almost 15%. In 1 managed Medicaid plan, we reduced the cost of care by nearly 20%. Our Medicare program has seen a reduction in cost by nearly 3%, and during the same time, the national cost has been increasing. So I think what we wanted to show you here through these efforts at both quality and cost, we've successfully taken on and produced results in an ACO and value-based care environment. So now getting back to the grant. So this slide was shown earlier, and I just wanted to revisit it here. I won't read it, but these are the goals, again, of the TCPI initiative. And what you can see on the next slide is how we've tried to outline for you today how our capabilities are aligned with those goals. Specifically, we've shown you here today how we've successfully transformed our own practice over the last 4 years. We've done this in the past by integrating and bringing on board new physicians, and we've also engaged the new physicians in the value-based care work and brought them up to speed with the goings-on in our organization. We've improved the quality of care. We've launched transitional care programs and our variation reduction program, which has successfully lowered the cost of care while improving the quality of care through best practice standards. And finally, we have successfully negotiated and performed well in a number of risk-based contracts. CMMI suggests the following 6 things as benefits for clinicians to think about in participating with this grant, and they're here. Optimizing the health outcomes for your patients, promoting connectedness of care for your patients, learning from high performers, more time spent caring with your patients, stronger alignment with new and federal programs, and finally an opportunity to be part of a national leadership in practice transformation. And we would agree with those things. And again, to reiterate what Scott mentioned early on in the presentation, what we're offering is a Crystal Run-led practice transformation network where we will offer guided mentorship and data assistance to each of you who are enrolled, and we're inviting you to enroll in this opportunity so that you can successfully enjoy the benefits that CMMI suggests here. Specifically what we're offering, and broken down again, we like to speak about our work like the triple aim. So our practice transformation network will do the following and offer the following to you. First is better health through teaching quality improvements and assisting with developing and ensuring the adherence to best practice standards so that our patients receive the best possible care. The next is better health care, working with things like choosing wisely in our variation reduction program to make sure that care is truly needed and non-duplicative and well coordinated. And in addition to that, assisting groups with attaining and using the infrastructure of the PCMH model to achieve better outcomes for their patients. And then finally, we will help you lower the cost of care by building upon the PCMH model and the infrastructure involved to start to tackle population management and using the variation reduction analysis to identify additional opportunities for reducing unnecessary and non-value added treatments. Going further again into what we're offering, these are the things that we would expect to be bringing to those who are in the Practice Transformation Network, and they're the following. One is a readiness assessment. We will provide and assist in developing an assessment of current state and opportunities for improvement in your organization. The second is to implement a data exchange capability. Although most of the work involved with this grant is around mentorship and teaching, a fair amount will be armed with data. We will provide you with a state of performance on a number of things in your organization so that you can understand how you're doing and where there are opportunities for improvement. We will bring our variation reduction analysis to you, not just in the data, but also in the facilitated engagement with physicians around what this data means and how to make improvements. Quality improvement we spoke about. We will offer PCMH recognition consultation, population health training with things like transitional health. We will also work on physician and staff engagement. A really important part of what we've learned at Crystal Run is that there does need to be a fair amount of time on why change and why do we need to change what we've been doing successfully for a number of years. And then lastly, we will provide assistance with risk-based and performance-based contracting. So again, just to kind of go through the phases that Dr. Hines mentioned early on, I'm not going to read this, but we wanted to be somewhat explicit to you about what would be expected of those who sign up for this network. Again, there is no out-of-pocket cost, but there is the cost of time and engagement so that you can work with us on achieving the goals of this initiative. So phase one, as we talked about, is setting aims and developing basic capabilities. You will need to recognize the need to transform, and by listening to this call today, hopefully you've already checked that box, but also a willingness to engage in an evaluation of your current state. And we will help you to do that with the things listed in the box on the right, including conducting the initial readiness assessment. Phase two involves reporting and using data to generate improvements. And again, this will be what will be required of those participating is to participate in the review of the current state, the outcomes of the readiness assessment, and then armed with data, a willingness to develop and work with us to help you implement quality improvements and best practice standards as an example in your organization. Phase three is achieving the aims of the triple aim. And again, part of this is then taking the initial readiness assessment that we've provided and the data and implement quality improvement, and then also participating with the faculty in the PTN to develop and achieve the PCMH recognition, and also utilizing its capabilities to advance some of the goals and initiatives that we have discussed. You'll see on the right there how we will help you do that. Phase 4 involves getting to benchmark status, and we think that this phase will require of you further implementation of the population health activities that we've developed in the first 3 phases. And we'll help you do that by consultation to achieve PCMH recognition, and then also through population health training, how to use care managers effectively to manage your sickest patients, as an example. And then lastly, phase 5 really involves demonstrating capability to successfully lower costs and improve health. And this involves risk-based contracting. And we think that sustaining the transformation efforts that are developed through the grant will be achieved by taking on risk-based contracting, and we'll provide assistance with that both in contracting and consultation on how to develop ongoing funding sources for the infrastructure that we've created with you through the grant. So again, this is the slide that shows the benefits. We really thank you for your participation in the webinar today, and would love for you to consider participating with us. We think that there are a number of benefits available to you, but not the least of which, or I think one of the most important ones, is to be able to work with our colleagues in the region on transforming healthcare here in the Lower Hudson Valley and New Jersey and the regions that we're speaking about on the call today. So next steps for you guys to think about, and then we're going to open up to questions, is the following. First of all, we're going to take questions. We're going to unmute the lines now, and if you could just introduce yourselves and go ahead and ask your question, we'll try to answer that for you now. If you'd prefer to email us a question, that's fine. You can also submit a question on the webinar. 2 other things that I just wanted to mention as we're thinking about participation is that, sorry, we've got a little echo here. So we're going to go ahead and unmute line. And if you have any questions, feel free to go ahead and speak to us on the phone, or if you'd prefer to submit something on the webinar, you can do that as well.
Yeah. Hello.
Yes.
This is Dr. Banker. I'm in Hudson Valley Haverstraw Pediatric in Rockland County.
Yes. Hi. How are you today?
Good. How are you? We are interested in pediatric. Most of the information we saw mostly was targeted for internists. And how does the pediatric practice?
So if anybody has us on hold or on their end, we're getting a fair amount of feedback.
It's probably somebody's speakerphone.
Yeah, if somebody has us on take us off speaker. We're getting a fair amount of echo and feedback. That's a little bit better now. So the answer to that question is regarding pediatrics. I mean, certainly a lot of the work that we've done here internally at Crystal Run has focused on our adult patients. But I'm a pediatrician, and I can let you know that we are doing a lot of work in pediatrics as well, both in variation reduction and in a number of the best practice standards that we've discussed here. Pediatricians are not excluded from this effort. CMS is certainly prioritizing those of us who are taking care of beneficiaries that are either Medicare, Medicaid, or CHIP. So if you're a pediatric group that has Medicaid patients that you're taking care of, by all means you would be eligible to participate in this grant, and we expect to bring content that's relevant to the care of children in addition to adults.
Wait, baby.
Yeah, I think what we're going to do, just because of the feedback, is to just mute the lines again. And if you have a question, if you could just submit it through the chat functionality, I think it would work better. I apologize for the feedback here, but please submit any questions that you have via the chat functionality. You can also send if you have any questions after the call today, you can also send that to Dr. Hines or myself via email. We're going to stay on the call for just a few minutes and just see if there are any additional questions that come in. Okay, go ahead.
How will you work with existing EMRs, in particular for behavioral health practices?
So the question is, how will we work with existing EMRs and in particular with behavioral health practices?
So as far as how we would work with different EMRs, that's part of the capabilities of being able to participate in this grant is that the PTN, so here at Crystal Run Healthcare, has to show the ability to be able to do this sort of data exchange. And so we have a variety of tools at our disposal to be able to do the data exchange. We're going to be collaborating with others who have expertise and abilities to do this. So we would develop a way that we would be able to have the individual practices submit their data through their EHR, have us be able to extract that data from their EHR, and we would work with you to be able to do that. That's one of the responsibilities that we have, so we will arrange all of that. As far as how we will work with behavioral health, again, we are open to and committed to working with all specialties that are interested in participating in this program. We have the ability to to scale our capabilities across multiple different specialties, and so we have behavioral health here at Crystal Run. We're happy to share the work that we've done to date with behavioral health through things such as virtual rounding, something we call MHAT, other programs that we have in place. But we're ready and willing to work with all specialties, all patients, all payers.
And one of the other things I just would add as part of that readiness assessment that we talked about is that individual practices will select their own goals and opportunities. So although the grant is prescriptive around its goals, those goals are general. And so individual specialties can choose from a menu of choices in terms of both quality measures that we would be looking at with them and also goals for participation in the grant.
And for another question?
Yeah.
Is this slide presentation available after the webinar?
Yes, we will be making this available. We've recorded it. It will likely be in a YouTube format, and we will send that out and would love for you to share that with whoever else might be interested.
So then we have a two-part question. It says, we are a pediatric group who just this past year were approved as a PCMH level 2. Can we be upgraded to a level 3 before the expiration of 3 years? What kind of demographic data would need to be submitted by January 23rd?
So the second part, the demographic data, we'll make available and we'll send everybody the Excel sheet. The demographic data that we're really looking for is just number of locations for a practice, the number of providers in each location, what EHR is being used, what current reporting capabilities exist, and a brief general payer mix sort of index. So that's all that we're looking for by next week. That will help us with our funding request to understand how many small offices we're working with, how many large offices, how we'll scale some of the work that we're doing. With respect to PCMH level 2, PCMH level 3, the assistance that we would provide to you would be in helping you to achieve the recognition, and we have a fair amount of experience with doing that both here internally, and actually Dr. Hines is a reviewer for NCQA. As far as whether you can do that before the end of the cycle happens, I'm going to defer to Scott.
Yeah, so if there's a, if you have a particular, if you have the ability to upgrade from a level 2 to a level 3, we would be able to assist you with that. There are some instances where that's able to occur if you show additional capabilities before the end of before your recognition expires, and so we could work with that group individually to figure out how we can do that.
All the questions before.
If folks have any other questions, please just type them into the question bar or the chat box, and be happy to take those.
I don't think you have any more.
Great.
Do you employ the NPs that conduct transitional care visits in the home, or is this function subcontracted? How many of these visits do you complete annually?
So currently at Crystal Run, we do employ the NPs that do the home visits. Our team at Crystal Run, and just to put it in context, we have about, we're focusing on our highest risk Medicare patients who are hospitalized, and we have about 10,000 total Medicare patients who have primary care physicians here at Crystal Run. Our team of employed nurse practitioners who do the home visits is 2, and we do approximately on the order of about 60 visits a month. So to put that in perspective of the year, you know, we're talking about 700 or so visits a year. What we would be providing in the grant is, you know, in transitional health would be a similar model. As an example, although we're still working through the funding opportunity here, we would provide initially in the grant some of the folks that would be needed to go out and do those home visits. There obviously we would need to be looking at the scale and how that would functionally operate, looking over the course of a number of practices. But we would facilitate the information as well back to those organizations for the providers who are going into the home. So we do employ those nurse practitioners here. As far as extending that out to the grant, we expect to bring that capability and that skill set to those organizations that are participating. Okay. So it looks like we're coming to the end of questions. Again, we really appreciate everybody's time today. We are a little bit under a deadline crunch as far as getting some information back from you guys, and the grant is actually due in the first week in February. But nonetheless, if you would like us to speak with you, if you'd like to speak directly with us, have some additional questions, feel free to email us. We'd be happy to get on the phone and speak with you. As was asked in the question, we will be providing this webinar in a recorded format so that you can share with members of your organization. And on behalf of Dr. Hines and myself, we want to thank you for your participation in this meeting today. And again,